the women's health topic. But even though you may be at a zero, guess what? Eventually you're going to see a female in your practice. All right, since 2015, we've had females in every part of the military. So it's not a matter of if, it's a matter of when, and you need to be at least somewhat prepared to answer the questions or at least know where to direct them. And also think about it like this. Every 2 or so hours you spend with me is 2 or so hours you are closer to graduation and getting the heck up out of here. So that's good. We need this to be a conducive learning environment. It's freezing, which is not super conducive, but in general, I'm not here for me. I'm here to help you guys, and I'm here to help you learn. I don't want any of you guys here at the end of this semester. My job is not to see how many people I can fail. I hate that even. So I don't want anybody. No one's ever failed, and this will not be the first time, right? But the key is knowing what you don't know and coming to me again early on. So if there's something you don't understand the way I'm explaining it, I can try to come up with a different way. I do try to break down these concepts so that we can understand it easily, but sometimes when the words coming out of my mouth, you're just like, what is she saying? So let's talk about that and make sure that we understand. We've got to be prepared for class. I know you guys have tons of exams today. I got it. But I'm going to tell you now, this class is not easy. It is not easy. You're not going to be able to just sit in here and be like, oh, I'm just going to pass. You're going to have to study. You're going to have to know the concepts. All right, so if you've got a big exam and you're not doing well in that class, and I see you studying, I'm not going to come up and berate you about it. That's up to you. But I do encourage you to pay attention because I do a lot of foot stomps, I do a lot of claps, I do a lot of, yeah, I'll get that. And if you're not listening to those, you won't get those on the exam as well. We have 50 minutes to talk, and that hour, if I go over, it is definitely not intentional because I don't want to go over either. Okay, I need my little 10-minute break too. So just wave your hand, hey, we're done, and time to take a break, and then we'll stop. When you leave here, you're going to a hospital. So our job really isn't to prepare you to go and see patients on your own. Our job is to prepare you for phase 2, hospital-based training. So you will see that some of the material that we're telling you is going to be really focused on hospital-based training, not practicing on your own. It's intentional. Okay. But the other thing we're trying to do is give you the information that you need to pass the PANCE exam ultimately after phase 2. So you'll get that from phase 1 and from phase 2. We've got 40 hours of lecture, 3 exams. We've got a simulation lab. We have RTA lab. RTA lab does not belong to me. Yes, we do female GU exams, or GYN exams, and male GU exams, but it belongs to the physical exam. What we will do before that hands-on experience with those live models, we will have a simulation lab to go through how do you do a pelvic exam, how do you do a breast exam. Okay? So I'm going to arrive on time. Please arrive on time. Please ask me any questions that you have, and then we hope to be successful, all of us, in the end. We do not teach to the NCCPA blueprint. We don't teach that. However, this blueprint is what forms the basis of the PANCE and the PANCE questions. So you've got to be familiar with what is on the PANCE and the NCCPA blueprint. Last PANCE, all of these different topics for women's health is on the PANCE. So this can be pretty complex because what we look at are patients that not only could potentially be pregnant, but could make it other non-pregnant issues. And what happens when somebody walks into your office and if they're 36 weeks pregnant after you catch your breath, you're like, this isn't the place for you. But I'm just coming here because I have this ankle, so I injured my ankle the other day. No, this isn't the place for you, right? Like, you're just like so afraid when you come in. But the key is you've got to be able to manage those patients. On your PANCE test, they're going to say, you've got a 32-year-old female who is 22 weeks pregnant who comes in complaining of, and it's a non-pregnant issue. What are you going to do about it? All right, so we got to do this. It's very complex women's health, and then when we add a pregnant patient into it, it becomes even more and more complex. The other thing that we're going to do is we focus on health, we focus on maintenance, we focus on prevention of certain things. Okay, so prevention, we are a very reactive society. We would like to be a proactive society, especially when it comes to medicine. And so we'll talk about some of these health maintenance things that we can do to make us more proactive and reactive. Not only because it's something we do as PAs, but it also provides us that one-to-one interaction that we can have with our patients. Education goes a long way. The patients may not like what you're saying. It's going to be a lot of times they don't like what you're saying, but they have to hear it in a very kind and intelligent way. And so you guys have probably already noticed since beginning PA school, you got a lot of family members, you got a lot of friends, they're always coming up and asking you these questions that you're just like, you do know I'm a phase 2 or phase 1 student, right? Like, why are you asking me that question? Because they think you know everything already, right? Your patients are going to think that too. And you're going to say, you know, yes, you're absolutely right. I know the answer to that question, but I want to make sure that I'm answering it completely appropriately. And in your mind, you're like, I have no idea, I have no idea. But you're not going to tell them that, and then you're going to get back in touch with them. We're going to educate our patients on the questions that they have. So we've got our TLOs and we've got our ELOs for this class. Okay, we're going to start off with really basic embryology, like really just a few slides on embryology. So we have to know, how does a female become a female? And really we're going to focus on that, but also how does a male become a male? When we we don't look at the sperm, but the sperm really is what decides. If the sperm's turned to X chromosome, then it's a female. If it's a Y chromosome, then it's a male. Okay? But sex differentiation itself doesn't happen immediately. Initially, for that first month or so, we have an undifferentiated gonad. We don't know if this is truly going to be male or female, or sometimes it's a combination. Then we have something called testes determining factor. So testes determining factor, and that's exactly what it sounds like. It determines, is this this child going to have testicles or no? Is it going to be male or not? If we have testes determining factor, we're going to develop testicles, and we're going to inhibit female structures. If we do not have testes determining factor, okay, then ovaries are going to start to develop, or the female reproductive structures are going to start to develop. There is something called Mullerian inhibiting factor, MIF. So the ducts, the female reproductive organs, the majority of them, are formed from these Mullerian structures, these Mullerian ducts form these structures. So if this is a female, we are going to have the lack of, or we are not going to have Mullerian inhibiting factor. If we have Mullerian inhibiting factor, it's going to inhibit those Mullerian structures from developing. Right, so females, they have the lack of, or they do not have Mullerian inhibiting factor. And they don't have a lot of testosterone either. They have some testosterone, but not a lot. And that allows for those male structures, or those Wolffian structures, to regress and go away. And the female structure that we're talking about primarily are associated with these Mullerian ducts. We talk about the uterus, the fallopian tubes, and then the upper portion of the vagina. So initially then, we've got two pairs of ducts. Two pairs of ducts. We got the male ducts, that are going to be the first thing that we see embryonic-wise. Okay, so we have those male ducts. Those are also called mesonephric ducts, or mesonephrons. Okay, and then within a couple of days, we're going to have those pair of mesonephric structures, or those Mullerian ducts that are going to develop as well. So we've got male initially, then we have male and female, and then at around the time of that differentiation, at 5 to 6 weeks, we're going to decide, is this male, is this female? If it is female, then what's going to start happening? We're going to start to have regression of those male ducts, of those mesonephrons. Okay, those mesonephrons are going to start to regress, and then the female structures and those female ducts are going to continue to grow into the normal reproductive structures for the female. Males are going to continue to regress and then ultimately completely go away. So those Müllerian ducts then are going to form, again, a good portion of the female reproductive system. It's going to form the fallopian tube, it's going to form the uterus, and it's going to form the upper third of the vagina. What we don't have here is the ovaries, which has nothing to do with the ovaries. We'll talk about those in a minute. Normally, we're going to have fusion of those two ducts. If we have normal fusion of those two ducts, we're going to have a single uterus with a cervix. Okay, we're going to have the upper portion of the vagina, one vagina, not two. Okay, and then we're going to have reabsorption of the middle portion of those ducts. Okay, so we see on top we have our Müllerian ducts. Our Müllerian ducts are out here. We've got our Wolffian ducts, which are our male structures here in the middle. We have regression of those male ducts, and then we're going to start our fusion of those Müllerian ducts, or paramesonephric ducts. Here we continue to have fusion, but what you can see here is we still have the middle that is there in between those two ducts. So about 16 weeks or so in utero, the female reproductive structure that kind of look like this. And then about 20 weeks or so in utero, we're going to have reabsorption of that septum in between the two ducts. And we're going to have what looks like a normal appearing uterus. You guys can see the difference between this picture and this picture. And this uterus is designed like that because remember, what's going to live inside the uterus for about 9 months? A baby. And so if we don't have enough room, if we don't have reabsorption of this septum, then we're going to ask that baby to live in an area like this, and there's not really enough room there for that baby to grow. About 0.1% of females are not going to have structures develop as normal. Okay, they're either going to have poor development or one or both of those Müllerian ducts. Maybe they don't have reabsorption of the septum in between the ducts. Okay? Maybe the ducts don't develop at all. Okay? So something is awry. And if we are one of those 0.1%, these are the different things that can happen as a result of those Müllerian ducts not developing appropriately. Someone can be born with something called uterus didelphys. Uterus didelphys is two uteruses. Two uteruses. Now sometimes, and usually this is from failed fusion of those Müllerian ducts, sometimes those two uteruses have one vagina, and sometimes those two uteruses have two vaginas that are attached. We can have something called the bicornuate uterus. In the bicornuate uterus, we have duplication of the upper portion of the uterus. So again, if you remember, if we look at this picture back here, the inside of the uterus should have kind of an open area. So if we have a bicornuate uterus, this top portion of the uterus is replicated, and instead the uterus is kind of divided into two different areas. Not a complete division, but we have a small area of the uterus here, a small area of the uterus here, and then we've got tissue in between those small areas. We can have a bicornuate uterus, what we call a rudimentary form. A rudimentary form means one of those ducts just didn't develop well enough. It's very small, it stopped developing after a period of time, and we still have duplication of the upper portion of the upper portion of the uterus. We can have that septate uterus, where normally at that 20 weeks in utero, the septum reabsorbs. Well, sometimes that doesn't happen. And if that doesn't happen, you're going to have this persistent tissue area in between the two sides of the uterus. Okay. And then we can have a uniporter uterus. With a uniporter uterus, one of those Müllerian ducts did not develop at all. And so we have just one horn, one part of the uterus that has developed. Now let me tell you about a story recently. I was seeing a patient in the emergency department, like a 20-year-old patient. She came in with ankle pain. It was nothing, but she's here in AIT, so you know they have to have their battle buddies, and so battle buddy was in there with her, and she talked about her ankle, and I said, okay, well the good thing is you did an x-ray, your ankle's not broken, okay. And I said, I think everything's going to be all right. Her battle buddy pipes up and said, well, yeah, well at least you don't have two uteruses. I was like, ooh! tell me more. Tell me more about your two uteruses. Like, complete, like your angle's totally fine. Tell me about your two uteruses. And so she said, yeah, she had no idea. I said, well, what made you find out your two uteruses? She said she was having a menstrual cycle like every 2 weeks. Every 2 weeks, every 2 weeks. And so eventually her mom took her in, and they said, oh, you have two uteruses. Now, that's unusual to have two uteruses, but also, or maybe it's two uteri, but also, most of the time, one of those uteruses is not active, like it's not effective, it doesn't do anything, it's just like a piece of tissue there. But hers, both were working. And I said, okay, well, I'm sorry. And I know this is going to be a crazy question, but what is the question that I asked? Do you have two vaginas? I did. How could I not ask her? Because they're looking at me like, did you really? I did. I had to know. And she's like, yes. I was like, oh my God, you gotta be kidding me. She got two uteruses and two vaginas. So that is the case. You have two uteruses and two vaginas. Now, typically, when you have the two vaginas, you don't have two holes. It's typically one hole as they tend to fuse as they come down. Okay, so but not always. Not always. Sometimes you do have two holes. You just don't know. And again, this is a patient that was, I think she said she was probably 16 before she ever even knew. She didn't even know. So for years, I think she had a menstrual cycle at 12, 11 or 12, she said. So for years, she didn't even know. So this very well could be someone that you guys are seeing in the clinics, right? Probably, if you're seeing family members, someone came in at 18 in the military or came in at 17 and they never really had medical care. This might be someone that you're seeing. How exciting. Not so exciting. All right. So then that leads us to, what about the ovaries? Well, the ovaries come from a completely different area. Actually, ovaries come from the gonadotropins, and those are considered ovary precursors. And then they develop into these corticocords, which are ovarian follicles. The corticocords ultimately develop eggs as well. And what we're going to see is that ovarian development occurs because of multiple cells. We have oogonia, those are the eggs. And we have theca cells. You guys remember theca cells from freshman semester? Granulosa cells. We'll talk more about those continually throughout women's health lectures. And so we have the development of these cells, and those development of these cells is really important for structural formation, but also for reproduction. Okay? And then we can split this up into probably two phases. The first phase is we have development of the ovary, development of those cells, and then we also have those primordial follicles. So the primordial follicles are start to develop about 16 weeks in utero. And then the second part of this ovarian development is when we have the maturation of those follicles and then ultimately have the release of eggs, and that's going to be more towards puberty, right? So we know that all the eggs that a woman ever is going to make is done in utero, right? At one point, we probably have in utero about 20 million eggs. 20 million eggs. And then about the time of birth, there's still about 2 million eggs. That baby, that female baby that's born, has 2 million eggs inside of her. 2 million. That's a lot. That's a lot of babies. That's a lot. Thank God for the way our body is designed. Some of those eggs start dying off immediately, and you have this spontaneous degeneration of these eggs over time. So at the time of puberty, we're going to have about 400,000 eggs left. That's still a lot of babies. I mean, I got 2. And I struggle, right? So 400,000 babies, that's a lot. But every month we're going to lose more and more and more eggs. About 1,000 eggs a month that we lose, right? So overall, we want to remember that we have no eggs that are produced postnatally. No eggs that are produced postnatally. They're all produced in utero, which is very different from the male, right? Because they produce like every 90 days. All right. That leads us to what happens if we have complications in any of that development. Disorders of sexual development that can occur. Now, this is not an endocrine class. We're not going to really delve significantly deep into this, but we want to point out a couple things that more commonly we'll see questions on the pants about. So we've got these congenital issues that can develop, can be chromosomal, they can be sexual in nature, which was usually associated with gonads, so for males, testicles, for females, ovaries. Or they could just be an anatomic abdomen, where females look like a female, but anatomy-wise, it looks a little bit different. Oftentimes, we're going to classify this based on what is the histologic appearance of the gonads. So what is the histologic appearance of the ovaries, or what is the histologic appearance of the testicles? Turner syndrome. I imagine during your endocrine class you learned about Turner syndrome, because there's always a PANCE question on it. Well, guess what? It's not only in the PANCE. I just took my PANRE last month, and there was a question on Turner syndrome on the PANRE, and that is my third PANRE, fourth PANRE, I think. They used to be every 6 years, and then they went to 10, so that was my second 10. So they're still asking questions about Turner syndrome. Well, why? Well, because it's one of the most common sex-related disorders that we're going to see in females. So it's not that you're never going to see it. You are going to see it. It occurs in about 1 in every 2,000 or 2,500 female births. And again, this is female only. So remember, we're born with, no person is born with 23 sets of chromosomes. Well, one of those sets of chromosomes are your sex chromosomes. And so if you have an XY, you're a male. If you have XX, you're a female, right? Remember that? Well, for Turner syndrome is XO. And what does that mean? Well, it means that that second X didn't develop, or it's missing, or something is wrong with that second X. And so that is the problem with these folks, is they don't have that second X for full female development. This is a problem where? Where is this a problem? Is it a problem at the pituitary, or is it a problem at the ovaries? It is a problem at the ovaries. And how do you know that? Because it's hypo. So our gonadotropins are FSH and LH. Right? So we have FSH and LH. If you have hyper, that means we have extra release of FSH and LH. Well, there's only a couple reasons why that happens. And the main reason is that the ovaries are not responding. So the pituitary says, all right, I got you. Let's send out more. I need you to talk to me. Ovaries can't talk to them. And we don't have that appropriate negative feedback because the ovaries are not responding. They're typically either non-functioning completely or very streaked, a very poor function. So this is a hypo, meaning your FSH and LH coming from the pituitary is elevated because it's not getting a response from the gonads. Right? The gonads are not functioning. They're not sending that negative feedback back to the pituitary to say, stop sending me all this FSH and LH. Right? We're not getting a response back. So hypo. And you got to know elevated FSH. You got to know elevated LH. And look at that estrogen and progesterone as well. Not only the board question, I will ask you a question on your exam about it. Okay, so I'm going to. So again, streaked gonads meaning they're just not functioning appropriately or being completely non-functional. For these patients, how do they typically develop? They typically develop more of that short stature. And why the short stature? What's going on? Well, yeah, if you don't have estrogen, we're not going to have that good development. So it's a decrease in that estrogen. Okay, we have the web neck appearance as well. And if some of these patients, you don't have their truly classic appearance. If you really looked at me like, okay, I can kind of see it. But some of these patients look fairly normal, right? You don't really see super web neck. They're a little bit shorter, but so are their parents. So sometimes what prompts their parents to bring them in is the lack of thelarchy. So thelarchy is breast development, or even the lack of menarche, which is a lack of menses. Right? So we have lack of thelarchy, lack of menses for these patients. Again, because we're not really going into puberty. We evaluate these patients usually by getting these hormone labs. We're going to get those gonadotropin labs, estrogen, progesterone as well, and then often genetic testing is associated with that. Treatment, we want to help these patients with this short stature. We want to help them grow a little bit as much as we can, so we give them growth hormone. we also tend to give them estrogen and progesterone as well, and that can help sometimes it even push them into the puberty and having some development. Remember that Turner syndrome isn't just a problem with those hormones by themselves. We've got a lot of other issues with Turner syndrome. We can have cardiovascular issues, we can have issues with the renal system, with bones, eyesight, hearing, all of those things can occur. So I would say, if this is a person that you're seeing in your clinic, because I know when I was in primary care, our pediatric clinic was overwhelmed. So we saw the well baby checks. We did all of that. We saw these kids in our clinic. Okay, so if this is something you're seeing, probably needs to be then ultimately seen by a pediatrician for primary care. Okay. Another sex chromosomal disorder is Kallmann syndrome. Now, Kallmann syndrome could be male or female. And here we have hormonal disorder, but we also, what is the key with Kallmann's? Remember? Smell. We have a problem with our smell. There's actually a gene mutation that's in the olfactory of the cells of the brain. And now, this is not hypo, this is hypo. And if it's hypo, that means the problem is in fact not at the gonads, the problem is higher up from that. And for these patients, the problem is all the way up at the top of your HPO axis. It's all the way up in the hypothalamus. So they're going to present low FSH, low LH, because they're not getting impulse, and then we have low estrogen as well. For these patients, oftentimes sex differentiation is normal. I mean, it looks like a male, looks like a female, but the problem is that a lot of times their secondary sexual characteristics are not fully developing. Okay, maybe for males are coming in because they haven't been able to, for infertility is a common cause for males to come in. Yes, they look maybe a little bit more feminine, maybe they don't have a ton of hair growth, but they don't think anything of that, but when they can't have kids, a lot of them will come in for evaluation. Okay? So for females, we talk about secondary sexual characteristics for females, no breast development, no menstruation. So again, it looks like a female, but when we go towards puberty, we're not getting those secondary sexual characteristics, the signs or the evidence that these patients are then going into puberty. The issue again is at the hypothalamus, and what happens is the part of the hypothalamus initially actually develops lower in the brain, so all the way down by the nose is where it initially develops. Right? And so when as the baby in utero continues to grow, then that part of the hypothalamus moves up and goes to the other portion of the hypothalamus. But the issue is down here, it also affects the olfactory nerves or olfactory senses. And so because we have this problem here, it ultimately comes up, these patients have an issue with their olfactory, an issue with smelling, and then we do not have appropriate release of GnRH, because GnRH is released by the hypothalamus. So neurons in the hypothalamus are not working appropriately, and it's not that it's not releasing at all. It's not that it's not releasing at all, because it is. If it wasn't releasing at all, we would identify something way earlier than before these guys go into puberty. The problem is puberty doesn't start unless we have pulsatility of GnRH. We have a normal release of GnRH every single day when we're younger. But as we get more and more toward puberty, we get GnRH that gets pulsatile released. So it stimulates in a fashion that's pulsatile. That doesn't happen with these folks, and so that's why they don't go into that empirical sequence as normal. Okay? So how do we treat these patients? Estrogen, progesterone, a lot of times they will give them GnRH injections, and that will help induce ovulation. HCG injection helps them increase the chance of fertility as well. And that leads us to the last thing we'll talk about associated with disorders of sexual development, and that is 46XX. And 46XX, what does that sound like? What's the problem? Any problem there? 46XX? Oh, no problem. That's pretty normal, right? For a female, 46XX. Okay, but so female appearing, and most of the time they have normal internal structures. They've got ovaries, fallopian tubes, vagina, uterus, all those things. But they could have a combination. So maybe those Wolffian or the mesonephron structures did not completely regress. So they could have a combination of ovaries and testicles. Okay? And the main issue with these folks is there's something that is causing them to be more virilized. So even though they are female appearing, and they do look, for the most part, female appearing, they've got female structure, there's something more masculine about them. Maybe they have excess hair. Maybe they have, we talk about this clitoromegaly. That is very possible in these patients. Oftentimes with clitoromegaly, it's usually some sort of tumor that is producing a bunch of excess androgen. But we can see this in things like congenital adrenal hyperplasia. We can see it in PCOS. We can see it in like a luteoma, where these patients are female appearing, but they may have testicles with ovaries, or they may just have very masculine appearing features. So with hair, a little bit of hair on their chin, maybe some other structure. Partial fusion of the labia. I have seen partial fusion of the labia probably a half a dozen times, again, when I was doing well baby checks. Most of the time it's nothing. Most of them it's nothing. It has to do with estrogen, and we give these patients non-pithal estrogen cream on the labia and no issues. But sometimes that's not the case. So if you are in the position that you're doing these well baby checks on babies that are 2 weeks old, 4 weeks old on up, and make sure you keep this in mind, that this may not be normal, and it's probably best to refer them to pediatrics to make sure they don't have any other issues going on. All right, that leads us to our female anatomy. Female anatomy. Now remember, we are going to be professional. We're going to do our damnedest trying to be professional. Sometimes, even today, I'm like, I don't know how professional I am, but we'll do our best. So when we talk amongst ourselves, we can use all the words we want. When we talk to consultants, we need to be able to use the right verbiage. Right? We need to be able to talk to them intelligently. So we're going to talk about the words that we use when we talk to a consultant and what do those words mean. Okay? Here we have the anatomy of the external genitalia. We have our perineum. Our perineum, if you were to imagine, this kind of looks like a diamond-shaped structure here. On the top of our perineum, we have our pubic symphysis. Okay, and then the bottom of the perineum down here is, we have our coccyx is down there. The perineum is divided into, kind of arbitrarily divided into the anterior, which is our urogenital triangle, and then posterior, which is our anal triangle. Again, the pubic symphysis is on top, the coccyx is on the bottom, and then our ischial tuberosities are on both sides of these triangles. These two triangles are separated in the middle by the perineal muscle and then this perineal body. Now, perineal muscle and that perineal body become really important, especially at the time of pregnancy and the time of delivery, because sometimes that perineal body, it's just a thick fibrous tissue. Sometimes that needs to be cut in the form of an episiotomy to allow the opening, the vaginal opening to increase, to allow delivery of that baby. So that's just a thick fibrous area that may have to be adjusted or cut during delivery. We have a lot of muscles in this area, but the two main muscles that we're going to see are the levator ani and the coccygeus muscle. And those are primarily located in the posterior canal. And again, those become really important. We later will talk about some female urogenital issues like pain with intercourse, or difficulty with urination, or difficulty holding your urine. They have a frequency in urination. We talked about those muscular structures. And there's a lot of different parts in our perineal area. We have the mons pubis, which is on top. Okay, the pubic mound is another name. We have our labia majora. Our labia majora is the outside labia. And then we have the labia minora, and that's located on the inside more towards the vaginal opening. We have our clitoral gland. The clitoral gland is located more superior or anterior, okay, above the vaginal opening. We have something called the vestibule. The vestibule, not vegetable, but vestibule. Okay, vestibule means really just door. It's Latin for door. Okay, the vestibule is located here in the middle. It kind of goes from the labia minora and then in through the hymen. This is your vestibule. And inside that vestibule, there are different structures inside the vestibule. We have the hymen in there. Okay, we have the urethral opening as well that's located in here. Another thing that we're going to have is we have these Bartholin's glands. The Bartholin's glands are going to be located just medial to the labia minora, right here and here. They're located about the 8 o'clock position, 4 and 8 o'clock position. That is really important when patients come in. They have some sort of mass or pain in that area. We'll talk about that later and what we do with those patients. And then we have periurethral glands. Periurethral glands are called Skene glands. They are located around the urethra. Okay, so because we know that sex differentiation does not occur immediately, there are some homologs between the male and female anatomy. The labia majora, that borrows from the male scrotum, so it's a homolog to the male scrotum. Over time, the healthiness or the appearance of that labia majora is going to change as the patient goes from younger to puberty to the postmenopausal period, and even during pregnancy. And in pregnancy, these patients come in and they're coming in for a routine evaluation. We may notice that the labia majora looks larger. They may notice that it looks a little bit different in color. Very vascular area. We can even get varicosities in the labia majora area as associated with increase in estrogen. We do have, it has round ligaments that are located on the upper borders and on the side, and then it tapers, the labia majora tapers posteriorly, and then they also merge centrally and they overlie where that perineal body is. We've got a lot of different glands that are associated with the labia majora. We've got the exocrine, we've got the apocrine glands, and we also have our sebaceous gland. And again, remember, this area is very vascular, so any injuries to this area can cause a significant amount of bleeding. We have the labia minora. The labia minora is medial to the labia majora, and then it's going to be a homolog to the ventral shaft of the penis. It's a different type of tissue than we're going to see on the labia majora. The labia majora has that hair, it has all those glands. We don't really have that many glands associated with the labia minora. It fuses superiorly. It forms a prepuce of the clitoris. And again, it can also change in appearance as patients go from younger to puberty and then postmenopausal time. What we're going to see is this labia minora is located here, medial to the majora, okay? But you also see this line here that kind of separates the labia minora. That is called the heart line. It's called the heart line. Lateral to that heart line, or outside of that heart line, so going more externally, is going to be this keratinized tissue. The keratinized tissue, or squamous epithelial tissue. And then medial to the heart line, going more towards the vaginal opening, is going to be non-keratinized tissue. Non-keratinized tissue. And that's important because what that allows for, it allows for that area of the vaginal tissue to stay more moist. It reduces the amount of microbes that can get into the vaginal area, and then ultimately up inside the vagina and up by the uterus, causing infection. So the way the body protects itself is to have that difference in the tissue, and then ultimately can reduce some of the bacteria that transcend into the vagina and cause the infections. The glands of the clitoris, that's homolog to the erectile tissue of the penis. Okay. We know that this is the primary female erogenous zone. It has two glands and two what we call crura. And what that does, the crura, they kind of just stabilize the clitoris down on the side, the tissue that stabilizes down the musculature. Okay. We have the mons pubis, that's a pubic mound. Prior to puberty, It's kind of just the inferior portion of the abdomen. There's no hair on it, but after puberty we have hair, and then we also have African external sebaceous glands associated with this tissue. The vestibule. The vestibule is like it's an amniotic derivative. Okay? So it's not the hymen, it's external to the hymen, but it's the area between the heart line of the labia minora and the hymen. The hymen is located on the inner portion of the vaginal opening. And inside that vestibule, we have a urethra, we have the vaginal opening down here, we've got our Bartholin's glands, and we've got our Skene's glands, which are our paraurethral glands. So those Bartholin's glands, 4 and 8 o'clock position, I would know that. And they are below the hymenal ring, and they are prone to infection. They are prone to developing cysts, and they are prone to developing abscesses. Now, the difference between a cyst and an abscess is owie and not owie. Abscesses hurt really bad. Typically, these patients have febrile, they're tachycardic, they are not feeling well at all. Cysts are uncomfortable, but patients are more presenting like, something just growing that doesn't seem to be right. Like, I don't know what's going on. They hurt. I don't feel bad, but it's just something that's growing in that area. Now, here's the thing. We've got lots of different glands in our vaginal area. So if it's not at the 4 and 8 o'clock position, you may have a cyst in a different gland, but the treatment may also be different. So we do specific treatment for Bartholin's glands because for Bartholin gland abscesses because they tend to reoccur. Skene's glands, those are going to secrete fluid to lubricate the urethral opening. Okay, so they're going to be found along and or outside the urethral opening. The hymen. The hymen is this collagen type tissue. Okay, it's connective tissue, and it's going to be just on the inside or posterior to the vaginal opening. We've got our vaginal opening, and a lot of time you have that hymen is going to, there's no perforation here, that hymen tissue is going to cover this vaginal opening. There's it doesn't take a tremendous amount to rupture that hymen material. A lot of times just insertion of a tampon will do it, first intercourse will do it. Sometimes if young female is riding her bike and her foot slips off and she hits her groin area on that middle bar, sometimes that will do it. Now some women, some females have very thick hymenal tissue, and it has to be ruptured by medical personnel because it doesn't rupture. And how these patients may present is they may present like this picture that we see here. Everybody see we have our vaginal area, we have our vaginal opening here, our labia minora, and then our vaginal opening. And can everybody see that looks like it's a little bit bluish in color? A little bit bluish in color. We can see it even better in this next picture. Well, what that is this patient did not have, so we're typically born with a small hole. Okay? Normal, like this little hole here, we're typically born with this hole in our hymenal tissue. And so when these patients go and they start their menstrual cycle, we already have that little hole there. Okay? We have at least a little hole. And so the menses is able to then come out of that small hole that is anatomically there. Okay? Well, sometimes that's not the case. Sometimes it looks like this, and we have no small hole. So when these patients start their menstrual cycle, they don't have any bleeding. How they're going to present is cyclic abdominal pain. Cyclic abdominal pain. Okay? How would we know that? They don't know. They just like, okay, well, I'm like 13, like I feel like I should have had my menstrual cycle, so the parents are going to bring them in, and like, well, what? Any signs or symptoms? No bleeding, no. You're going to have to ask them. Think about this. Is there any time of the month that you will have a couple of days where your stomach is really kind of hurting, it's cramping a lot? Well, yeah. And you got to do an exam, and a lot of times you'll see this on exam. Even if there's not their time of the cycle now, you'll still see that discoloration because we have dry blood behind that hymenal tissue. So again, there's different ways this hymenal tissue can present. This hole here can be a really, really small hole. So again, they may have pain with menstrual cycle because they're not having much of a relief that menstrual, that bleeding, that blood. We could have multiple holes. We could have holes like this. Right? So anything that is, at least if we have a small perforation, we'll have some bleeding out. But if we have no perforation at all, these patients may have that sicker abdominal pain. Anybody watch The Pit? It was on The Pit. They must have got it from me. I already had this on here. I already had this on here, by the way. And I was like, wait a minute, they stole that from me. All right, let's take a break. Internal genitalia, we have the vagina, which is a musculo-membranous tube. Goes from the hymen all the way to the uterus. It has a large amount of vascular supply, so it's very vascular, which means if there's any injury to the inside of the vaginal wall or the vaginal canal, these patients will bleed pretty significantly. So y'all may know this, I didn't know this, but the thing to have piercings in places that didn't used to be pierced. And so during intercourse, sometimes one of those piercings will cause lacerations in the vaginal wall. Trust and believe, I've seen this a couple times, these patients come in and they are hemorrhaging. They are bleeding all over the place, and you got to get some pressure on there pretty quick. Okay? So these patients come in, and they might want to get a history on them and see what has happened. But a lot of times if they have a laceration anywhere in that vaginal vault area, they're going to have a lot of bleeding. We can see this even during delivery, especially if it's like a forceps delivery. So very, very vascular. And this is a non-keratinized stratified squamous epithelial tissue. And so it's that more sensitive tissue. We have a smooth layer and an adventitious layer. That is elastin. So that allows for the vaginal vault, the area to stretch. And the vaginal tissue itself, actually no glands in the vaginal tissue. No glands in the vaginal vault. All the lubrication or lubrication measures are what we call transudated. During pregnancy, we may notice that patients tend to complain more of increased secretions, and that's really just due to the increase in vascularity. And although it may sound like increased secretions, but what does that help with? Well, that helps with reducing the amount of infections these patients may have during pregnancy, because that increase in secretion, the bacteria doesn't live well in those secretions. Postmenopausal time period, we have a decrease in estrogen, and that decrease in estrogen ultimately results in a loss of Lugay. So these patients have more friable vaginal tissue, more irritant vaginal tissue. They don't have as much stretch, and so they may come in with irritation and pain with intercourse because of that loss of estrogen. So estrogen plays a big role in the vaginal tissue structures. The cervix, that is the lower portion of the uterus. We've got an internal os or opening which goes to the uterus itself, and then we have an external os of the cervix which comes out, and that's the part that we see. You can see that more exterior. So internal os and external os. We've got the upper portion, which is the portio supravaginalis, and that's above this vaginal attachment here. That vaginal wall, the vaginal vault's down here. This is your cervix. Okay. On examination for the cervix, if this is a nulla parus person or nulla gravid person, so never pregnant, never have a baby, typically what we're going to see is the external os will just have a little hole in there. It's a little hole. And then if this is a person that has previously been pregnant or previously had kids, oftentimes you will see a slit-like appearance. Slit-like appearance. I would encourage you when you do the RTA lab to pay attention when you see the cervix, and you should be able to identify on that cervical exam whether or not this patient has had kids or not had kids. If they haven't had kids, they're a little round. If they had kids, it's going to be more split-like. This is our ectocervix here. This is what we see on physical exam. It is stratified squamous epithelial cells. And then the endocervix between the ectocervix Okay, so the external os and the internal os, we have this endocervix that goes up towards the internal os. This tissue is columnar epithelial tissue. So initially we got that stratified squamous on the outside, on the inside we got columnar epithelial tissue. As a person ages, what happens? Do you guys remember from anatomy and physiology?
Transition.
It spreads out. So the columnar epithelium starts pushing that stratified squamous epithelial cell outward. And that is an issue because anytime we have change, increases the risk of cancer. We call that the transformation zone. That transformation zone, some patients have a very, very clear transformation zone, and other patients don't. But when you guys do your women's health exams or cervical cancer screening exams, you're doing a PAP. The cervical transformation zone is the area that we want to make sure we get cells from and send those off for evaluation. During the speculum exam, so you can see our cervix is here, insertion of the speculum here. We can see fornices. We have 4 fornices. We have one on the top of the cervix, one on the bottom, our posterior portion, and then lateral walls. And these are the areas that we are using to assess with our bimanual exam. So bimanual exam is we have one hand externally on the lower portion of the abdomen, kind of suprapubic area. We have 2 fingers internally, and we're feeling in those fornices. We go on one side, we go on the left side, because what else is in those fornicate areas? Our ovaries. Not our ovaries, their ovaries, the person's ovaries. Not all of us have ovaries, but the ovaries are there. So we're going to feel that here, feel here, and then, especially if someone comes in and they have signs or symptoms of concern for endometriosis, that's really when we can feel that posterior and anterior to see if the cervix moves at all. Cervix is typically a little bit mobile and usually not terribly painful. It's uncomfortable, but not terribly painful. So we're using our fornices to help us be able to do recessed areas that we can use. We shouldn't have anything in there. We don't typically feel ovaries. We shouldn't be able to feel the ovary over there in the fornices, on both sides and anterior and posterior to the cervix. The uterus is a pear-shaped, kind of upside down pear, I guess, right? Any nulla gravid or nulla parens person, so a person that has never been pregnant, then it's about 6 to 8 centimeters in size, and the multiparous is about 10 centimeters. So once female has a baby or has been pregnant, the uterus enlarges and it stays larger from then on out. Now, if they had a miscarriage earlier on, we may not see that enlargement quite as readily. In a non-gravid person, so a person that is not currently pregnant, that uterus is going to lie between the bladder and the rectum. We already know that the lower portion of the uterus is the cervix. So we've got the isthmus that joins the body or the corpus, okay, and the cervix. Okay, and then we have the fundus. The fundus is up here. Up here is the fundus. What do y'all remember about the fundus? You can do a fundal massage, right? If you're postpartum, someone's bleeding, or postpartum, once they deliver, you can do a fundal massage, okay? And then we've got the posterior wall of the fundus. What do you remember about that? What happens there? Hopefully, implantation, hopefully. So we'd like the baby to implant up here, okay? So if it implants up here, that allows room for baby to grow. That also allows room for the cervix, what am I thinking of? Baby. Placenta. The placenta to grow. It also allows room for the placenta to grow. Because if baby implants down here, the placenta has to grow as that baby grows to provide nutrients for the baby. If the baby implants down here, you have a much higher likelihood of having something called placenta previa, where that placenta then overlies that internal os. And guess what? If you have placenta previa, Babies cannot come out of there first. Babies cannot come out before the placenta comes out. Babies have to come out before the placenta comes out. Okay? The myometrium, that is the muscle part of the uterus. Okay? We have smooth muscles, we have this elastic muscle to allow the uterus to enlarge during pregnancy, allow it to stretch. And the way that these muscles are designed is they interlock with each other, kind of like a woven into each other. Okay? And that allows for once mom delivers, or if we have any hemorrhaging of the uterus, it allows for those muscles to become super tight pretty darn quickly. Okay? So the way that they're interwoven with each other. And that helps us reduce the amount of postpartum hemorrhage or reduce the amount of bleeding that a person may have for some other anomaly that's going on inside the uterus. The endometrium, that's considered the functional layer of the uterus, and that lines the inside of the uterus. It's important because as a woman, a female goes into puberty, okay, and they're going to start to have their menstrual cycle, and the endometrium is what sheds every single month. Sometimes people can have irritation of the endometrial lining, endometritis, and that's an infection, and those patients can get pretty darn sick from that. And they can go not only from the endometrium, but into the myometrium as well. There's also something called endometriosis. So we typically say about the endometrial lining is on the inside of the uterus. That's where it lives. Well, with endometriosis, somehow that lining on the inside has gotten outside of the uterus, and it can be anywhere, not as just in the pelvic cavity. I have seen endometriosis in the pleural cavity, all the way up by the lungs. I have seen endometriosis in scar tissue from like a prior C-section or appendectomy was coming out of the scar tissue. So somehow that endometrial tissue gets out of the endometrium. But ideally we want it to stay in the lining of inside the uterus. Now, the general position of the uterus is what we call anteroverted. The general position is anteroverted. So this is anteroverted. And so when we do our examination, we're going to do our speculum exam. We're looking in here. We can see the external os here. And when we do our bimanual exam, we can see that this kind of comes out by the lower portion of the abdomen, by the suprapubic area, and we'll be able to feel that fundus on our abdominal exam. Sometimes the uterus is mid-plane, okay, so that means that we have to push in a little bit deeper to be able to feel that fundus, because we're feeling that fundus to make sure we don't feel any lumps or bumps that aren't supposed to be there. Sometimes it is retroverted, or is pointing more towards the back. So this is your uterus. Now, there is occasionally an anatomic problem with only the fundus, so just the top part, the muscular top part of the uterus. Sometimes the fundus itself can be anteflexed. Sometimes it can be retroflexed. So imagine, if you will, you have a person that comes in and they say to you, I have a retroverted, retroflexed uterus. How does that change, or how does that have different physical exam implications?
The positioning of the speculum?
Yeah, so oftentimes you can still sit with the speculum, you just have to insert the speculum and you got to come way down like this. Well, normally, for most people, when you insert the speculum, the cervix is kind of right there. Like for my patient for the RTA, it's the same patient I've had for 3 years. We're down like this. She has a very retroverted uterus. Not retroflex. It's not retroflex, but it's retroverted. Okay? So hers is way down. Okay? But you may not be able to feel the fundus on your bimanual abdominal exam. So bimanual exam with your other hand on the abdomen may not be able to feel it. If they tell you that it's retroverted and especially retroflex, it might be a rectal exam to be able to feel that fundus, the top portion of the uterus. So it does have physical exam implications because it might have to change the way the speculum physically inserts only one way. But then once you're inside the vaginal vault, then you may have to move it down or may have to move it up based on the anatomic abnormality that the patient may have. So again, we've got different uterus positions, and based on these different positions of the uterus, it may have implications on the physical exam. Do I, in my mind, like, okay, well, I guess we won't even try to do a biennial exam, we'll just do a rectal exam. No, I'm still doing my biennial exam because I'm still looking for other things. And a lot of times, you know, if they're not having any other issues, this is a routine evaluation, I don't necessarily have to feel the fundus of the uterus. But you're still doing your biennial exam to make sure you don't feel anything in those cornices. Okay? But the way that the main impact this may have is that speculum and how you may have to angle your speculum up or down based on the positioning of the uterus. And most of the time, people have no idea. Most of the time, there are some people that be like, yeah, they always say my cervix is hard to find. They say it's retrograde. I don't really know what that means, but in your mind, you're like, oh, I know what that means. I got it now. The development of the uterus differs at different stages of life. So we can see that our newborn has a little uterus, but that little uterus here is still bigger than a 4-year-old. Why would that be? Why would we have a newborn uterus bigger than a 4-year-old? Mom's to blame. Mom's to blame, right? That's mom's estrogen actually is to blame. Okay, so mom's estrogen is to blame, and then that estrogen goes away, and then we don't really have a ton of circulating estrogen at 14. From puberty, we get bigger during our reproductive time frame, and then menopause hits. We ain't got no estrogen, not even a drop, and the uterus kind of shrivels and gets a little bit smaller and smaller. Okay. Fallopian tubes. We know we have typically have two fallopian tubes, or muscular tubes. They are connected to the uterus, but they are not connected directly to the ovaries, right? Because remember that the ovaries aren't free floating, but they're just not connected directly to the fallopian tube. There are different components of the fallopian tubes. The main portion that we think about is the ampulla. You also have the isthmus. You have the intramural, the interstitial portion as well. So what is the most common site of fertilization? The ampulla. What is the most common site of ectopic pregnancy? The ampulla, right? Because sometimes once we're fertilized, the baby doesn't move into the uterus like we want to. So the fallopian tubes themselves, even though they're attached here, they're also enveloped into these broad ligaments. At the end of the fallopian tube, we have these finger-like projections, these fimbriae. Okay? And the job of the fimbriae are to come out and whisk up the egg once it is released from the ovary. Now, what happens if someone had to have one of their fallopian tubes removed? A salpingectomy. So let's say your right one's removed, and the right ovary releases an egg. Is the egg just out of luck?
Yes.
No. What happened? The left fallopian tube picks it up and brings it back. Crazy! That's some crazy stuff right there. Like, that is so crazy how our body is designed. But it surely does. It can sweep on over. They can sweep over to the other side and grab the egg and bring it over and put it in. I felt the exact same way you guys are looking like me. But that's what the literature says. But I don't want to know when it's happening. Like, just don't tell me. Don't tell me that that's what you're doing, because that's weird. I don't want you to be all the way on the other side. What are you doing over there? All right, we got ovaries. We got 2 ovaries, a pair of ovaries. I don't know. Some people say about the size of the almond. Some people say about the size of a small walnut. So somewhere in between there, 3.5 centimeters or so in length, about 2 centimeters wide or so, about 1 centimeter thick. So not all that big. Not big enough to feel them on physical exam. If you're doing your biennial exam and you feel something on the lateral aspect of our cervix, okay, in that, kind of that recessed area, that would be unusual. We normally cannot feel them on physical exam. Again, ovaries are not free-floating, they're just not attached to the fallopian tubes, they are held within the broad ligaments. And then also in the suspensory ligaments as well. We know that the ovaries secrete estrogen and progesterone, okay, those are gonadal hormones that are secreted, and they have a lot of blood supply, so a decent amount of blood supply comes from the ovarian and the uterine arteries. The ovary has different cell layers, and we have the epithelium really is on the outside, and that's the cell that we get most concerned about, because every month that a female ovulates, they break that external portion of the ovary. So the epithelial cell lining breaks, they release the egg, okay, and then that epithelial lining heals itself. So that's every single month. Again, any time we have consistent change like that, it increases our risk of cancer. So the most common ovarian cancer that you're going to see is epithelial ovarian cancer. Ovarian torsion can happen. Ovarian torsion can happen. Now, ovarian torsion is when the ovary will turn on its suspensory ligament and turn on the blood vessels and cut off supply to that ovary. If you were to guess which ovary is more likely to become torged?
One.
Right.
Okay.
The right side. And that's because on the left side, we have the colon. And the colon kind of protects and helps so that that left ovary is not quite so mobile. Right? It's more apt to torch. What's that? The musculoskeletal pelvic anatomy. Musculoskeletal pelvic anatomy, we have a true and we have a false pelvis. True pelvis, we think childbearing, this is a true pelvis. False pelvis is up here by our PSIS, that's our false pelvis. This becomes really important if baby has a big head, okay, so like a macrosomic baby that we may see in like a diabetic. They can often have macrosomic babies or a history of macrosomic babies. Or if mom was in some sort of car accident, or in the military, let's say it was a paratrooper. The paratrooper had a bad landing and broke their pelvis. Okay, so it can change that true bony pelvis housing. And the true bony pelvis doesn't allow for a lot of give. We have a little bit of give on this ligament here, okay, but otherwise we don't have a lot of movement in that true bony pelvis. So if we have any sort of damage to the bones or the muscle around that, we don't allow for the expansion, and sometimes baby can get stuck and can't be delivered vaginally. Sometimes mom will try, and again, baby can get stuck. So sometimes before, if there's been any sort of car accident, before they even attempt vaginal delivery, they'll do it used to be a physical exam, and they'll be able to identify if the mom is going to be able to deliver vaginally or not by physical exam. I remember many times in phase 2, I went to phase 2 at Fort Campbell, which is, I will tell you, probably the most amazing phase 2 site ever. For those of you that are going to Fort Campbell, come back and tell me otherwise, because I will argue with you till my death. It was an amazing phase 2 site. But what we used to do is we do like this gun, and we take our fingers and we put 2 fingers in, and this thumb stays externally, and depend on if you could feel the pelvis or not, would depend on if they could deliver vaginally, because they would tell you stuff about them. I don't even remember, but I did lots of them. Because in phase 2 at Fort Campbell, there's no other learners. So I carried the pager for surgery, I carried the pager for OB, which was like the scariest days of my life. I paged me, there's a baby being born, like right now? Like I got it, oh. Praise God that somebody else is in here with me. It was terrible, but also so good, right? So if anything impacts that true pelvis, then potentially the implication would be that mom cannot deliver. We have pelvises that are favorable, and those are pelvises that are not favorable. And again, specifically we're talking about probably vaginal delivery. A guided cord pelvis, most favorable for vaginal delivery. See that's underlined right there? Gynecoid, most favorable. Anthropoid, okay, anthropoid sometimes, okay, but it's more oval in shape. And then we have android and platypitoid. So we think about the androids, which are like Martians and androids. Platypuses and Martians, they don't tend to deliver babies very well, naturally. So think about that. But gynecoid and anthropoid, we can do it. Gynecoid is the most favorable. That leads us to the vascular structures that we may encounter for patients, especially patients that have to go undergo a C-section, a cesarean section. We've got these superficial and deep vasculature that provides blood supply to the pelvic area, to the lower abdominal area as well. And what we'll see is that the vessels kind of come medially towards the umbilicus, and then they transcend upward and upward here. And these are under a lot of pressure. Okay? These are under a lot of pressure. They actually come off from the iliac artery. So if you cut one of these, probably going to know that it was cut. Right? Probably going to have a decent amount of bleeding. We used to do C-section incisions a little bit higher, kind of up in this area here. So if your mom or grandmother ever had a C-section, you may notice the scars up a little bit higher. Well, by virtue of doing that, you run the risk of potentially having an increased risk of cutting one of these vessels that are coming up here, the superficial deep vessels. So what they've done is they've moved the incision lower. It's called a Phanestoel incision, which was so crazy because about 2 years ago, we had a Lieutenant Phanestoel here. And it was his grandpa. His grandpa, or maybe it was his great-grandpa, but that created this Phanestoel incision. So he was here. So it's a little bit lower. So it's not that you can't hit those vessels, you're just a lot less likely to hit those vessels. Now, you most of the time are not going to be doing a C-section. The majority of the time, you might do it in phase 2, but pray to God you don't have to do it afterwards. But what you may see, okay, you may see these patients come in after these incisions where they're having complications, where they have wound dehiscence or they have infection. So you may see those patients. And the reason why we do horizontal incisions and not vertical incisions, so we don't do up and down incisions, we do vertical incisions. Why? What have you learned in derm about the way that the skin is set up? Langer's lines? No. Well, Langer's lines. So Langer's lines, if we look at the way that our skin is set up and our nerves, our structure set up, it goes more in a horizontal fashion. Okay? If you cut along the horizontal fashion, we're going to have a lot better, a lot less scarring, a lot better healing in these patients. If you go along the tension lines, you go opposite to our tension lines, okay, and anytime you make that incision, we have constant pulling of that incision from one side to another. Okay, so you want to go in line with the tension line. You do not want to go against the tension line, which is why we do that incision in a horizontal fashion, not a vertical fashion, so we can avoid those high tension lines and reduce the risk of wound dehiscence and wound infection. All right, now, again, another thing, this is the last thing we'll talk about, we'll be done. Another thing you may see, but this is important because you may see it here in another week or so, is this low transverse incision that we're going to see. If someone comes into you in the clinic about 6 to 8 weeks after a C-section, and they say, I have this decrease in sensation kind of on the lateral aspect of my glute or even in my lower abdominal area, it might be an indication not that a vessel was cut, but that a nerve was transected. That a nerve was transected. So loss of sensation of the lateral glute or that hypogastric area about 6 to 8 weeks after their C-section, because initially they're going to say, well, it was just part of the C-section. But it's persistent now. They're going to come in and see, like, why do I have this numbness? Your indication is most likely that that iliohypogastric nerve was transected. And they're going to be numb in that area from here on out. That is it for today. Thank you.